Welcome to Real Health with me, Karl Henry. Folks, Professor Robert Byrne is Director of Cardiology at the Mater Private Network and one of Ireland's leading cardiologists, specialising in coronary heart disease, women's heart health, and is also Professor of Cardiovascular Research at RCSI. He brings clear practical insights on the unique heart health challenges facing women from 30 to 50, from stress-related conditions and hormonal transitions to overlooked symptoms and emerging risk factors. Professor Robert Byrne, welcome to Real Health.
Thanks very much for having me.
How's it going?
Good, yeah, all good. Busy morning, so just come down from the hospital and looking forward to chatting about these issues.
Talk to me about heart health in women. How prevalent is it? How aware are we on a societal level around issues related to heart health for women?
Yeah, there has been a little bit of bias over the years in terms of heart disease being considered a male condition. And that's something that we've been trying to address in recent years and recent decades. If you look at any of the registries of patients with heart disease, you see something a little funny. You see about 70 or 75% of the patients are men. Whereas if you look at the population register and look at the death register, you see about that deaths are relatively evenly split between men and women. So it suggests there's some type of a problem. Heart disease, despite our best efforts, does seem to be somehow under-recognised or underappreciated in women. Now that might be due to the fact that doctors have some type of a bias and think of it more frequently in men, or it might be that women are more reluctant to present their symptoms to a doctor for investigation. So there could be a couple of factors at play.
And how did you get into the area of heart health? Has it always been your passion?
I suppose medicine was something that I was interested in throughout my school days. I went to medical school in UCD. And then in Ireland, we have a good training programme which exposes you to lots of different specialties over the first 2 or 3 years. So you rotate through different surgical and medical specialties. You rotate around the country. So I worked in Mater, I worked in Beaumont, I worked in Galway, I worked in Wexford, I worked in Portlaoise, I worked in Donegal, I worked in St. James's Hospital. So you get lots of different exposures, but cardiology was the one that seemed to hit home for me. I also had the opportunity, actually, which was fortunate, to do an elective in cardiology working as a junior doctor in Arizona, in the Mayo Clinic in Arizona.
Oh, yeah.
And probably that's where the initial seeds came. I spent 6 months working there. And that's where the initial idea really came together.
And you're just back you were in Germany after that, weren't you?
Yeah. So after I worked in the HSE system here for 7 years, and then I went to Munich to pursue a research project for a year, and ended up staying for 13 years. And so I spent more of my time working in the German healthcare system, perhaps in the Irish healthcare system. But I'm back now about 5 or 6 years and well settled in.
Chat to me about the warning signs that are commonly missed in women with regards to heart health from ages kind of 30 to 50 or beyond. Like, what are the early symptoms that are often missed?
Yeah. So I suppose getting back to that kind of prevailing bias that exists a little bit, when people are worried about heart disease, they think mainly about heart attack, and they're thinking mainly about blockages in the heart arteries that can suddenly interrupt flow and give you chest discomfort or chest pain. There are studies to suggest that men are more likely to get a typical pain, which is a constricting chest pressure, severe pain. And interestingly, it's localized normally in the middle of the chest, not on the left. Everyone knows that the heart is on the left of their chest, well, nearly always. But the chest pain, the nerve endings to the heart are such that when you get pain related to the heart arteries, it tends to be in the middle of the chest. And that's the typical pain. If you take women, overall, by and large, they are still likely to, as not to get that type of symptom, but they also have a higher proportion of what we call atypical symptoms, which might be just a shortness of breath or a discomfort maybe in the back instead of the chest, or in the jaw or arm instead of the chest. So looking at studies, we think that classical presentation, it's slightly more common in men, and women need to be on the lookout for those classical symptoms, but also other symptoms. The other one that we see from time to time, and is a discomfort or an indigestion or a burning type of feeling. Now, of course, commonly that's due to a problem with your gastric system or some reflux, but it can be a sign of heart disease, and it's probably slightly more common in women.
And of course, some of those symptoms can be misconstrued as anxiety or stress. They're because they're less like the obvious signs that people would consider for heart disease.
Yeah, that's true. And you can present also with kind of more focus on your breathing and with the breathlessness, and of course that can get tied up with anxiety. You can have palpitations, racing of the heart rate, but in general, racing of the heart rate is quite a common condition, and there may be many people listening who have racing of the heart rate, which is a benign phenomenon. That's something we see a lot of, but if you're not sure, it's something to talk to your GP or eventually a cardiologist about, and there's normally a couple of quick tests that they can run and say, listen, this is something that requires further scrutiny, or no, we can offer reassurance quite early in the process.
Do you think women they just think that, oh look, it's fine, I'm too busy, I'm gonna get on with it? They're almost afraid to present it.
There is something in that. So the other problem that we have is doing research. And when we do research projects, we tend to find that more of the patients that volunteer for the research projects are men than women. And when you dig into it in a little bit more detail, it seems that women are somehow a little bit more risk averse. So they say, well, I'm not willing to participate in a research project because I have other responsibilities, and I have people that I feel responsible for, and maybe they're less likely to altruistically volunteer to participate in a study, if that makes sense. That seems to be something that comes out of one of the reasons why women are slightly underrepresented in research projects. So it's not uncommon in our area to pick up a paper in the Lancet or the New England Journal, the main medical journals, and look at a study and say, this is 75% or 80% men. And we're making a lot of efforts now in research to try to make sure that enrollment in research projects is independent of gender or sex.
We all get stressed from time to time, and a little bit of stress can be a good thing. It's very normal. But we know chronic stress is a big issue with regards to heart health. Tell me a little bit about that.
Yeah. You're right to first point out that a little bit of stress is actually good for performance in lots of areas in life. But you're right. Chronic stress is something that it's a risk factor for common or garden heart disease, what we call coronary artery disease, typically due to cholesterol buildup in the heart arteries that can come to light suddenly, an abrupt occlusion of blood flow that's a heart attack, or more slowly, in which case the patient notices this chest discomfort regularly when they exercise or exert themselves. And we know that this condition is what we call multifactorial. So part of it is due to your genetic makeup, and there's no doubt that family history of heart disease is something that makes a doctor's ears prick up and say, well, this is something that might require a bit more scrutiny. But then there's all of the other modifiable risk factors, of which there's cholesterol, there's blood pressure, there's diabetes, there's cigarette smoking, and there's stress. And stress is well researched as a risk factor for common or garden coronary heart disease. But there's also a couple of specific conditions that are rarer but are very tightly associated with stress. And there's two, one called spontaneous coronary artery dissection and the other called Takotsubo cardiomyopathy. Now, they're quite rare conditions, but they're clearly stress associated, and they have about a 9-to-1 female preponderance, which is interesting.
Wow. And the first one, it's minute tears in the heart, isn't it? The SCAD.
Yes. So this SCAD, or spontaneous coronary artery dissection, it manifests to all intents and purposes as a heart attack. And sometimes it will be a woman who's otherwise fit and healthy in her 30s, 40s, 50s. They come with symptoms, and you do an ECG. So the first port of call in that we're worried about in the hospital when we see a patient who's unwell with hospital is we do 12-lead ECG, stickers on the chest to figure out what's going on. And there's certain findings that are characteristic for a heart attack. And we now realize if this is a young woman, younger than we would expect, that this SCAD is something that could be behind it. It requires an angiogram to find it. So normally, if it's an emergency, you're thinking about heart attack, Ireland has a very good system for 24/7, 365 angiograms, and you get brought to the near hospital day or night, weekend, bank holiday, whatever, and you'll have your angiogram done by a cardiologist. And the cardiologist will be trying to detect, is this regular cholesterol buildup or is this small tears in the heart arteries? Like the heart arteries are like branches of a tree, and sometimes these small tears can be out in the peripheral branches of the tree. They can be a little bit difficult to detect, and in years and decades gone by, we probably missed it in some proportion of cases, but now cardiologists are much more aware of it, and often we find it, and normally we can offer patients reassurance and say, listen, this is something that's likely to heal up over time. It doesn't require typically strong medications over time. It doesn't require stents. It doesn't require bypass surgery. There's a small risk of recurrence. Of course, that's something that people are worried about because it generally afflicts people who are in the whole of their health, and this comes as a big shock. So we try to provide them with reassurance in that regard, and then monitor them in the background over the years to come. But normally they do very well.
Okay. High blood pressure. Prevalence is increasing in the female population. Chat to us a little bit about blood pressure and high blood pressure.
Yeah. So high blood pressure, the first thing about high blood pressure, a lot of people probably realize you don't usually get any symptoms from high blood pressure. So it's something that you won't know about it unless you have it checked. There's a rule of thumb among doctors that blood pressure gets higher as you get older. Past performance is not a guarantee of future success, and even someone who's never had blood pressure at some point in their life, usually in middle age, they'll suddenly find that they do have high blood pressure. And we the rule of thumb say it probably affects about 30% of people in their 30s, 40% of people in their 40s, 50% of people in their 50s, to some extent.
50%. Wow.
Yeah, and most people don't know they have it. Most people, if they know they have it, don't get well treated for it. And it is probably, of the modifiable risk factors, it's one that we should do a better job as a medical community of picking up and treating it. Now, you'll know yourself. If you go to your GP, oftentimes your GP might be in for a consultation about something. We'll just check your blood pressure as you're in. That's called opportunistic screening, and it's a really good way of picking up blood pressure. So if you're in your 30s or 40s and you don't know what your blood pressure is, go into a local chemist, get your blood pressure checked.
What should it be?
So ideal blood pressure is 120/80. When you're at rest, and we accept up to 140/90 as being within the normal range, and over 140 or not over 90 is elevated. Now, that's at rest. When you exercise, as a healthy person who doesn't have high blood pressure, your blood pressure will go up as you exercise. You put your body under stress, it'll go up to 140, 150, 160, 170. And that's not high blood pressure. That's just a normal blood pressure response to exercise, the same as your heart rate response to exercise. Everyone knows very well heart rate zones and things like that, but that's the same with blood pressure. So it's a resting blood pressure that we're interested in, and it should be at rest. Ideally, you wouldn't have drank any stimulants or caffeinated beverages. You'd be sitting relaxed for a few minutes before you have your blood pressure checked. It's quite common that people have high blood pressure because they're worried about going to see the doctor. White coat hypertension, most people will know about that. But there are tests we can do to tease out whether or not someone has white coat hypertension. The two best ways, if you're not sure, is to buy a blood pressure monitor yourself and check it at home. Keep a diary for a week or so, and you'll soon figure out.
That's a handy piece of kit, isn't it, for people to have at home?
I think so. And people don't need to be going around running around measuring their blood pressure all the time. But I think it is a handy bit of kit to have at home and get a feel for what your blood pressure is like in the home environment. The other way of doing it is you just go into your GP or a hospital or any large pharmacy, and you can get a 24-hour blood pressure monitor. Now, the nice thing about a 24-hour blood pressure monitor, it gives you a profile. You bring it back, you get a PDF, and you can see a profile of your blood pressure day and night, even while you're sleeping. And it can detect people who have elevated blood pressure, for example, at nighttime when they're sleeping, that they wouldn't otherwise know anything about.
Do we see, with the increase in use of smart tech and smart watches, are they helping with regards to picking up abnormalities, or is it is the tech not there yet?
No, they're definitely helping. So they help primarily with heart rhythm disorders. So I said it's quite common that people get palpitations or a sense of heart racing. If you have one of these devices, you can simply acquire an ECG during the time that you have the symptoms and show it to your doctor, and you can almost know straight away whether it's anything to be worried or not. So definitely in terms of heart rhythm disturbances, tech is good. You know, it can pick up subtleties. So a lot of the smartwatches will do ECG traces. And I've seen patients with very serious heart disease whose initial manifestation was they took an ECG on their phone, picked up some minor abnormality that set in motion kind of a cascade of testing, and eventually it transpired they had very significant blockages in their heart arteries. So it does happen. Of course, you can imagine the converse is also true, that doctors and patients get a lot of alerts from their smartwatches that turn out to be absolutely nothing and cause more worry than maybe benefit that they do. So, doctors and healthcare systems need to come up with a better way of assimilating all of this information into our kind of diagnostic algorithms and treatment plans. But I think it would be wrong to write off tech as saying that it's not helpful. It is, and it's only going to get better.
Which is good.
Yeah.
Chat to me about stimulants then. Coffee. You mentioned stimulants there. So tea, coffee, caffeinated drinks. What do they do to the heart?
Yeah, so all of these drinks that you mentioned tend to be caffeinated beverages, and they cause acceleration of heart rate. They cause acceleration of blood pressure. That's why I said if you're having your blood pressure checked, don't drink caffeinated beverages. And there is an association with heart rhythm disorders and caffeinated beverages. So if you look, there's a condition called atrial fibrillation, which is a very common irregular heart rate. Actually, it may be slightly more common in people who exercise a lot or people who have very athletic or well-trained hearts. There's some studies to suggest that atrial fibrillation can be a little bit more common. Now, it's typically a benign heart rhythm disturbance rather than a life-threatening heart rhythm disturbance. But there's also people will have triggers for why they get atrial fibrillation. It might be cold water immersion, it might be stimulants, it might be alcohol. So some people in the population will say, listen, I know for sure if I do X or Y that I'm going to get a bout of palpitations and atrial fibrillation if that's a condition that they've been diagnosed with. So there was a recent study published in the last few weeks that says, okay, let's take patients who have this atrial fibrillation condition and who have required treatment in hospital, and let's randomly allocate them to one of two programs. Program one is you completely eliminate coffee from your daily routine, and program two is you have one coffee a day instead of 2 or 3 coffees per day. And they expected to find that people who eliminated it completely would do better. But actually, they found the opposite. And those who had just a single coffee per day had a lower rate of these heart rhythm disturbances than people who abstained completely.
You've just made our listeners very happy.
Yes. So they think it might be something to do with withdrawal. And these were people who were used to drinking a couple of coffees per day. So listen, obviously a lot of people can get by with drinking 2 or 3 coffees per day and have no issue with it. But there are certain people who have medical conditions or heart rhythm disturbances who are just more sensitive to it than others.
And you mentioned cold immersion there. Of course, on a societal level, hot and cold is trendy.
Yes.
Hot saunas and immersion or Wim Hof and all of that.
Yeah.
Is that something that we need to be aware of with regards to cold immersion?
Listen, I think it's no harm to be aware about it. Certainly, I think the benefits of cold immersion or sea swimming or sauna therapy, they're also well defined, and you can find doctors who have opinions against either of them, but I think on balance it's felt that these are thought to bring more good than do harm. But there will be the occasional person who's just very sensitive to cold immersion or heat and who it mightn't agree with, but I think at a societal level kind of moves in this direction are all generally positive.
Menopause and heart health, talk to me about that.
Yeah, so I suppose women in the premenopause phase are protected, relatively speaking, from heart disease by virtue of circulating female hormones. So if you take a look at the heart attack registry in Ireland, which records everyone in the country who has a particular type of heart attack in any given year, you'll see that on average, women are 7 years older than men when they develop a heart attack. And we think that's because of the protective effect of these female hormones. Now, the converse is also true, that once these female protective hormones have left the body, then the risk of heart disease in a woman starts to catch up with that of a man very, very quickly. So I think it's important that people realize in the post-menopause phase that it's particularly important to keep an eye on their heart health, particularly important to concentrate on all the other modifiable risk factors like physical inactivity, like smoking, like cholesterol, like diabetes, like blood pressure, and to be more conscious about that, particularly as they go through menopause. I mean, going through menopause itself obviously can give symptoms, many of which overlap with cardiac disease. And of course, that can be a cause of concern, but it's usually easy enough for doctors to trigger out if heart racing or palpitations is due to changes going through menopause, or if it's a manifestation of heart disease.
And you brought it up there, which is the lifestyle modifications. I suppose that's the crucial part of our conversation. Is there are so many lifestyle modifications that we can make to reduce the risk factors for heart disease in men and in women.
Yeah, I think it's important. As I keep getting back to this heart disease, it's multifactorial. A proportion of the risk, there's not much we can do about it. It's not modifiable, but a large proportion is. Cigarette smoking is a big one. And again, if you look at the heart attack registry in Ireland, it's a registry of smokers. The good news about cigarette smoking and heart disease is it's never too late to stop. Now, that may sound trite, but it's true. Smoking is like adding fuel to the fire, or lighting a match in a room full of fumes. So if you stop smoking, your risk of having a heart attack drops very, very rapidly. And within 1 year, it's probably similar in many respects to the risk level of the background population. So it is smoking. It's definitely never too late to stop. And heart attack in young people, smoking is disproportionately involved as a risk factor. Other modified risks, of course, diet, and we could talk for hours, I'm sure, on diet, but there's been a lot of research on it, and a diet of moderation, a Mediterranean type of diet, seems to be the one of all the diets that have been investigated to be the one that's sustainably associated with the lowest risk of coronary heart disease. That's, things in moderation. If you like red meat, fine, once or twice a week, but otherwise, other days, white meat, fish, plenty of fresh fruits and vegetables, cooked with olive oil, nuts, seeds. The main probably thing is as little processed food as possible, which all have hidden fats. I think that Mediterranean type of diet, avoiding the excessive behaviors, particularly smoking, and then regular moderate intensity aerobic exercise. And there the studies suggest 150 minutes per week is the threshold at which, if you're doing that, then you're doing most of what you can do to reduce your risk. We normally tell people the benefit is probably in the moderate intensity range rather than the high intensity range. Now, when people are young, of course, we all enjoy high intensity exercise, but then as you get into middle age and a bit older, it's probably the moderate intensity exercise that you should be focusing on more, and less of the high intensity spinning classes or things like that at a certain point in life. And sometimes we don't recognize when that point in life has come.
And of course, if you are spinning, moderate intensity spinning is yes. All right. We won't defend any of the spinning instructors.
No. But moderate intensity, I think, is what's good for the heart. And also, we know that weight-based training is also, that tended to be something that was neglected in the past, but that's also an important part of staying healthy and avoiding heart disease.
And of course, weight is a risk factor in heart disease risk.
Weight is a big risk factor in heart disease. And in Northwest Europe, in Ireland, in the UK, we tend to have a particular problem with weight. If you look at the charts, If you go, to cardiology meetings, in Europe, and you look at the maps of Europe, they see that Northwest Europe, this part of the world we live in, does seem to have a slightly higher prevalence of obesity than other parts of Europe for a variety of reasons. And obesity, particularly central obesity, is a significant risk factor for heart disease. You'll also be aware, of course, that there are many therapies apart from diet and lifestyle interventions to reduce weight. And if you purely have a cardiologist hat on and look at some of these injectables, the data in terms of reducing heart risk over time seems credible and real. So, there are other factors that come into play with these medications. They're relatively new. I think it's right to be cautious when any new medication comes on the market, because we don't have a full idea of the full life cycle effect of this drug until we have 10, 20, 30 years experience with it. But the preliminary data from the studies that we have so far looks like it's obviously very good at for most people at causing them to reduce weight, but it also is good in reducing heart disease risk. So if you have a number of those modifiable risk factors that you haven't been able to shift, you're probably likely to derive more benefit in terms of absolute terms.
COVID-19 and heart health?
Yeah, COVID-19, it was a crazy time, wasn't it? I mean, it's hard to believe that it's 5.5 years ago. And you may remember one of the concerns, we had this kind of flood of information that we got, but there was concern in the summer of 2020 that preliminary research from some German doctors was suggesting that COVID-19 caused widespread cardiac scarring, and it might not become apparent until a later stage, and it could then be a chronic condition. So when we saw this research published in over the course of summer 2020, we found it a bit puzzling because it wasn't tallying what we were seeing. And we immediately set about doing quite a large study called the Satanta study. We worked with a couple of GP practices, and we said, listen, give us a list, talk to your patients about everyone who has recovered from COVID-19, and let's invite them in for a detailed cardiac screening, looking specifically for subtle signs of cardiac scarring or heart muscle scarring that might be missed with general testing. And we put them all into an MRI scanner, and we analysed the data. And what we found was a much more reassuring picture than what the German researchers had found. We found that scarring of the heart muscle seemed very much to be the exception rather than the rule, very infrequent. There were some manifestations of heart disease due to COVID-19. One in particular was a tendency for it to cause autonomic dysfunction. So that means when you're exercising, it's like, God, normally I go for an exercise, I know if I do this much, my heart rate will go up to 120, but it's shooting up to 140. So there's definitely something in that. It seems to be transient after COVID-19. Some people are affected more than others and can struggle for a while, but normally they get over it. But this scarring of the heart that we're worried about in the first wave, it never materialized, and we don't seem to think that's a long-term issue.
Final question. If you have a heart attack after our big long conversation, what should you do?
Yeah. So I think if anyone is concerned about having a heart attack, it's a very simple thing to do. It's to call 999 or 112. And it's the type of thing, if you wake up at 2 o'clock in the morning with severe chest discomfort, do not wait until the morning time to do something about it. That's what emergency services are there about. And we know the strain that the emergency services can be under. But I think it is important, if a heart attack is a suspected diagnosis, then you're not overreacting by ringing the emergency services. That's what we're there for. In Ireland, the services are very well set up, particularly over the last 12 or 13 years. An ambulance will go to you. An ambulance will do an ECG straight away. The technicians will hook you up, and long before you ever get to hospital, they'll be able to have a fair idea of whether this is a heart attack, blue light, or this is something that maybe requires further attention down the line.
If people want to find a bit more about the study that you're doing or get in touch with you, throw us the website address.
Yeah, so you can go to cvridublin.ie. That's the Cardiovascular Research Institute in Dublin. There you can find details on some of our publications, and you'll find links in particular to the Setanta study. You can also look up the Setanta trial on Google, and that'll point you in the right direction. There's a published manuscript which is aimed more at medical professionals, but it's available for free to consult if there's something that lay people might be interested in as well.
Amazing. A very important topic. Thank you so much for coming into the studio. I really appreciate it. Fair play. Yep. Folks, that is it for another episode of Real Health with me, Karl Henry. As ever, you know where we are, at Karl Henry PT on Instagram, realhealth@independent.ie, and on the Irish Independent website. We'll see you next week for more Real Health. Slán go fóill.